So we're going to get a little bit more basic, but we're going to examine many of the issues that were discussed this morning from the perspective of cell injury and repair, from the perspective of cell injury being a signaling event for pro-inflammatory signaling. And towards the end of the presentation, I'll visit the issue of hypocapnic acidosis and what it may mean for the lungs' response to deforming stress. Just to remind you of the phenomenon cell injury, as discussed yesterday, there are very, very good morphologic correlates to ventilator-induced lung injury, which show that plasma membrane stress failure and repair is an integral mechanism or an integral event in the pathogenesis of this syndrome, at least with respect to high volume injury of the lung. We've discussed methods with which one can demonstrate the phenomenon in experimental animals, as is shown here. A subpleural image, an optical slice of a lung that has been mechanically ventilated at an injurious setting. And I've explained to you that the use of membrane impermeant label allows you to characterize the injury, and not only the injury but also the repair. And we ended up where we discussed the implications or the consequences of plasma membrane stress failure, A, with respect to necrosis, and B, with respect to some of the repair mechanisms which require lipid trafficking. And we'll address a little bit what consequences these have for the gene response with respect to pro-inflammatory signaling. I think it is worthwhile that we sort of take a step back and ask ourselves first, what are all the biophysical determinants of ventilator-induced lung injury? And we've visited all of them in various respects. They're not entirely independent from each other, but clearly we've heard that overdistension of relatively normal lung units is an important mechanism. Well, what that means in cell biologic terms is that the lung is deformed, so cells have to assume shapes that they would not assume during normal breathing, even during stimulated breathing. You may translate this into volume information and say the lung is being stretched beyond its structural limit, exceeding what you would define as total lung capacity. And if you think about it in those terms, then we get back to plateau pressure and have to ask ourselves that exceeding total lung capacity usually means mechanically ventilating a patient at plateau pressures that correspond to volumes exceeding total lung capacity. And depending on a patient's chest wall compliance, that may mean a plateau pressure of 30 or may mean a plateau pressure of 50. There is no unitary answer, but that must be integrated. But that's clearly not the only mechanism by which we injure the lung. There is more to lung injury than a single inflation beyond total lung capacity, which clearly we probably do during a recruitment maneuver. So the repetitive nature of it and how we get there, all of that seems important. We heard about interdependence, or the shear stress between neighboring units with different volumes and transmural pressures. And I have more examples of this. It'll be easier to discuss when we look at these examples. A slightly different perspective that gets to some of the forth and back between Luciano and me about how low volume injury may damage airways. Something that Art Slutsky has pointed out in the Musaderi paper a long time ago. I'll discuss how cell injury may play a role in this mechanism. And one thing that we really haven't talked a lot about, but I believe that is integral to high tidal volume injury, whether you exceed total lung capacity or not, is the fact that you do inactivate surfactant if you force the alveolar unit to have large surface area changes on every breath. Because what has to happen on every breath, surfactant has to get adsorbed to the air-liquid interface as you go from end expiration to end inspiration, and the area increases. And then during expiration, the surfactant film buckles. There is so-called squeeze out. Some of the material goes back into the subphase to be re-recruited during the next breath. No process is 100% efficient. Some of the proteins misfold. So with every breath, there is some loss of activity, which is more than made up in you and me by type 2 cells replenishing what's being lost on the breath. But if I were to ask you to hyperventilate, and I take care of your carbon dioxide, and if I were to ask you to do this for an hour or 2 hours, I predict that I can measure subtle changes in your lung mechanics on account of imposed surfactant inactivation. So this, of course, has to be integrated with all of these mechanisms. I'm reminded by a study from Kolobow's lab many years ago where sheep were made to hyperventilate by injecting salicylate in the cerebrospinal fluid. And many of you know that pulmonary edema is part of, or maybe part of, salicylate toxicity. Now, cause and effect and mechanisms are not established by this experiment. Nevertheless, the spontaneous hyperventilation induced in sheep through this intervention caused pulmonary edema by presumably a surfactant inactivation dependent mechanism. So if you accept that as a possibility, then your perspective, whether assisted ventilation, pressure support ventilation, spontaneous breathing in somebody with acute lung injury or ARDS is more beneficial than mechanical ventilation, and whether the potential damage could really be uncoupled from tidal volume becomes an open question. Does the lung really know the difference, whether it's been pulled to a big tidal volume by respiratory muscles or pushed by a mechanical ventilator? I think those are relevant and interesting issues to discuss and consider. So I promised you a slightly different perspective, and I think it's useful to be aware of the work by Don Gaber, and Billig is the first author of this. And as Art has taught us a number of years ago, small airways, conducting airways, tend to be the targets of low-volume injury. And we've come to understand this as an opening and collapse phenomenon. And I've argued that this opening collapse phenomenon is simply the flow of a plug of liquid forth and back. And most people understand the opening and collapse phenomenon as having a airway that simply is collapsed in physical terms. But when you really think about it, what matters is what forces does this gas bubble that's being pushed in this direction exert on the lining cells of this airway. Now, qualitatively, there is little difference in this problem. Quantitatively, there may be a big difference whether this airway is collapsed in those terms or simply occluded by a fluid bridge. And Don Gaber is working at this with pencil and paper or with computer. But I think it is important for us to understand that even in a model system where you don't have collapse, the interfacial forces here are sufficient to damage the lining cells. So when you grow cells on a glass slide and blow a gas bubble by and label the fluid with a membrane impermeant label, much like I showed you yesterday, propyridium iodide. So you can see, at least from my angle here, these orange dots are hard to see, but you can see that these cells that grown on this glass slide have taken up this membrane impermeant label, depending on the surface tension at the air-liquid interface. So in fact, what happens is, because of the radius of curvature of this gas bubble that's moving by, there is a suction pressure that's exerted on these cells that's large enough to damage their plasma membranes. Quite independent of, so these cells don't have, the walls don't have to physically rub on each other. Now, when you think about edematous lungs, you appreciate that you all had water in the ears, in the external ear canal. You know how difficult this is to shake this out. Well, this is what happens when you have alveolar and small airway edema, and that's why I'm so fond of the notion that some of the mechanics in the injured lungs are the mechanics of foam and trapped gas in small spaces, at the scale of heterogeneity that Dr. Niemann showed us today. And so this is so not every cell injury has to do with an extraordinary shape change. It also has to do with the apical side of the cell being exposed to abrading forces. And the abrading forces could be the opposing neighboring cell in a collapsed airway, or it could simply be the fluid that's being pushed along. Interestingly enough, if you add surfactant to a system like this, then you lower the surface tension sufficiently that the cell doesn't get injured anymore. So I thought that was worthwhile discussing. So I was, when Art published the isolated unperfused model, in which, in the Mosaderi paper in 1994, I thought that he had focused on a mechanism that really in a perfused lung in the intact thorax wouldn't happen too much. But I've sort of changed my mind because there's a lot of evidence from a lot of different models that including the perfused preparation that we've been working with, that it is not that hard to find a lot of epithelial sloughing and damage in small airways. It simply happens. Now, I can't tell you whether this was because these airways rubbed on each other or because there was fluid. All I know is this is a grossly edematous preparation. There's another sort of interdependence phenomenon that you see here that's worth noticing. There's a lot of red blood cells around this blood vessel. Well, I mean, you could say, well, where are they going to be if the blood vessel ruptures? That's where they're going to accumulate. But the other way to think about this is here you got a steel pipe relative to all this elastic material around it. So this is the little hexagon in Luciano Gattinoni's presentation, where this thing simply can't change volume or area, and all the stress is at the insertion sites where the parenchyma attaches on the blood vessel. So this is where edema accumulates in the perivascular space, and this is where stress failure occurs, and that's why you have bleeding in the interstitium in a preparation like this. The other thing, remember that what is stress? Stress is force per unit area. It has the same units as pressure. And to the extent to which everything else expands, but this area remains small, the force per unit area, as all the insertion forces increases. And so having steel pipes in this elastic material causes stress concentrations. And that's the manifestation thereof. And here we go. I think one of the ways, as you've heard from Dr. Cardinone, as you heard from Dr. Neiman, one of the ways positive airway pressure works is, A, it prevents the liquid bridge formation in small airways. I mean, you can think about it, it's stenting the airways. So if you don't have a liquid bridge to begin with, the chance that a liquid bridge will form is less. You've seen this slide a couple of times, and I think it's worth maybe spending a second or two on it. So what was done here, this is a mechanically ventilated, isolated rat lung that was perfused with a fluorescent dextran solution and Krebs. So what you see here in white is edema fluid that's fluorescing. The gray stuff are the alveolar walls. And embedded on all these are these air bubbles. And so notice that these air bubbles have different radii of curvature. They have different size. So that means the pressure in them and or the surface tension in them cannot be uniform. What that means is they're not in communication with each other. They're trapped. So one way of thinking about a crackle when you listen to a patient's chest isn't necessarily that you've got this airless alveolus that sort of pops open. Another way you can generate a sound is by breaking foam. And again, it's like everything in biology. It's not an either or. There's probably a whole spectrum and continuum, but clearly we shouldn't discard the possibility that much of what happens in an edematous lung is having to do with the mechanics of foam. And you don't need to have physical collapse of the lung as we think in terms of a dry atelectasis during anesthesia in order to damage the tissue. Well, once you take this perspective a little bit further, in that case, the danger to injure a lung in somebody with heart failure through mechanical ventilation might not be all that different from the danger in somebody with ARDS, except that heart failure is very easily treated. And it's usually not a condition that persists forever and ever. But sort of the treatment principles, when I approach a patient who has cardiogenic pulmonary edema, certainly no PEEP works for a whole host of reasons. Part of the reason is also shown here is that it helps to redistribute fluid. Think about, by giving PEEP, you sort of taking fluid from the air spaces and putting it back into the interstitial space. And from a mechanical perspective and from an injury perspective, that can only be helpful. So this slide emphasizes that PEEP also works by redistributing fluid from the alveolar space back into the interstitial space, and I've borrowed this from work by Parker, who's pointed this out, and Larry Wood's group has looked at this in the 80s, and it's not the only mechanism by which PEEP works, but I believe it's an important one, particularly when the barrier function, when the epithelial lining is disturbed so that hydrostatic forces, in fact, force the fluid back. And you can appreciate this. When you raise lung volume through positive alveolar pressure, you squeeze out or you compress all these alveolar vessels. Fine. But what you also do is you actually put a relative suction pressure onto the space between the alveoli. Because, again, this space is a lot stiffer than that space. And so in a way, when you have a bag full of ping pong balls, the radius of the ping pong balls determines how much space is between the balls. And if I make the radius bigger, and I apologize to using a balloon analogy of the alveolar space, but nevertheless, when I increase alveolar size, I also put a traction on the interstitial space, that tends to then suck fluid from here to there, and these perivascular fluid cuffs are simply the manifestation thereof. We've heard from Dr. Uhlich that NF-kappa B transcription factors seem to be a common final pathway in the immune manifestations of ventilator-induced lung injury. And you can certainly, in many organ models, you can mechanically ventilate the lungs to injury, you can grind them up, and you can go ahead and do a genomic search, and you find all kinds of genes upregulated, having to do with both pro and anti-inflammatory activities. You could do the similar thing, in fact, on isolated cells. I was peripherally involved in this genomic search of stressed alveolar epithelial cells, stressed both by LPS, but also stressed by deformation. But the point of it is the mechanism by which this happens, the sensor and the mechanotransduction pathway, at least in principle, ought to consider cell wounding. So what you got here is a monolayer of cells. So this is cell culture. And somebody comes along and takes a scalpel and scratches this. So the cells along the edge of the scratch are wounded. And then you see in green here labeling of NF-kappa B, which is a transcription factor, which is usually inactivated in the cytoplasm of the cell. And for it to do its job, to turn on what's called CXC chemokines, interleukin 8, and so forth, it needs to go from the inactive cytoplasmic form to the nucleus and turn on genes. And that's what happens here. Okay? So there is nuclear translocation of NF-kappa B shortly after the scratch. And it's interesting, it only happens in the cell at the wound. So clearly, wounding and repair of a cell is a sufficient stimulus to set up a pro-inflammatory event. This brings me to this slide here, which Jorge Barrios stretched alveolar epithelial cells and looked at the response in terms of ICAM1 expression as a readout of pro-inflammatory signaling. ICAM1 is an adhesion molecule. It's in the family of immune globulins, and it's in endothelial cell. It mediates the interactions between white cell and endothelium. In epithelial cells, it probably mediates the interactions between macrophages and the epithelium. And all it points out is that a deforming stress can be a pro-inflammatory stimulus with respect to this signaling molecule. And if you look here, the mechanisms involve NF-kappa B, but that's not why I'm showing this. What I'm showing you here is that the temporal gene response differs a fair bit whether you do this experiment when you stretch the cells very quickly with very big strain rates, as opposed to when you stretch them slowly. Both elicit a response, but the temporal response isn't the same. Makes you wonder whether the signal transduction for the two events is the same. Well, what happens when you stretch cells and look at the wounding response? This is work from Nick Lahakis, and Nick set up a technique where he can measure not only how many % of cells are injured during a given experiment, but also how many live, heal, versus how many die. Okay? The point of this is if you stretch more, and this is just a single stretch, and you do this very fast, the more you stretch, the more injury you get. Now let's look at just this bar. But rather than stretching very quickly, let's slow the stretch. What it shows is if you give the cell long enough to adapt to this deforming stimulus, you can double the size of the cell, you can poke it, you can pull it, it can adapt, and there is no injury to speak of. Makes you wonder whether the different temporal profile in gene response that's related to strain rate progresses by different signaling mechanisms. The quick one may be a true injury response signaling in response to plasma membrane stress failure, whereas the slow one could be involved with cytoskeletal remodeling. I mean, clearly the cell knows that it deforms. It's not surprising that genes are involved in all of these events. And the tough part that we have when we assess the genomic response of a system to deforming stress is, what are we going to call injury and what are we going to call adaptation, and what's good and what's bad? That is always the issue. How much time do we have? 7 minutes. Okay. I just want to make a few comments about hypocapnia, because clearly one of the side effects of protecting the lung is to worry less about carbon dioxide. Or at least I've learned not to worry much about it, realizing that there is still a fair bit of debate about what one should do about it. One cannot talk about permissive hypercapnia without acknowledging the work by Brian Cavanaugh and John Laffey, and I just picked their first paper from the Cavanaugh group just to remind myself to acknowledge that work. And it was pretty remarkable because it pointed out in this ischemia reperfusion model that if you looked at filtration coefficient, that is the leakiness of the capillary, as a surrogate endpoint of injury, that doing an experiment under hypercapnic condition prevented that leakiness. And a series of papers followed, culminating in this, I believe, was the first whole animal experiment related to ventilator manipulations that showed that several measures of injury having to do with hemorrhage, meaning physical stress, capillary stress failure, and barrier function, edema formation, when conducted in a hypercapnic environment, appeared to be beneficial. So now the whole notion came up, well, maybe we ought to talk about therapeutic hypercapnia. Well, as you know, I'm interested in cell repair. So what does hypercapnic acidosis do to cell repair? And in a paper that came out this year, we sort of looked at this. So when you use a cell scratch model and ask yourself, well, how many cells survive this scratch? How many heal their injury? Then it's quite clear that more cells heal the injury when you do the experiment under normocapnic than when you either do it under hypocapnic or hypercapnic conditions. When you ask that question in a whole lung, in the isolated perfused lung preparation, then you confirm the observation from Cavanaugh's laboratory that, in fact, normocapnic injury tends to cause more edema, here simply measured as weight gain, than hypercapnic injury. And when you do the experiment under hypocapnic condition, and ventilator-induced alkalemia is not all that uncommon, you get a lot of edema. Okay? So if edema is your endpoint of injury, this is good, and this is really bad, and this is in between. I need to get rid of... thank you. But if you look at what happens to the cells, it's interesting that when you look at the distribution between necrotic cells, cells that fail to heal, and cells that survive the insult, hypocapnia, even in the intact lung, tends to produce more necrotic cells than normocapnia. Now, don't go away and say, well, that means that I shouldn't tolerate hypocapnia in my patient. As I commented yesterday, having an angry healed cell that tells all its neighbors, I'm angry and why don't you produce cytokines, may be just as bad or worse than knocking off the cell, having necrotic and having a phagocyte come in and clearing it up in the first place. But nevertheless, that's sort of a different kind of readout of repair. And what the long-term consequences of this are is interesting to us. And I'll conclude just with a comment on what happens when you buffer the system. And what's plotted here is the percent necrotic cell in the cell scratch model as you go from a hypercapnic acidic environment to one in which you buffer with bicarbonate, an intracellular buffer, tromethamine, or an isocapnic control. So you've got the least amount of necrosis or the most of repair when you do it under isocapnic control condition. And it's the worst when you have hypercapnic acidemic conditions, and buffering tends to have a beneficial effect. And if you repeat this in the whole lung, it is interesting that when you use bicarbonate buffer, not only do you decrease the amount of cell injury, you also seem to benefit the repair. And what's interesting about this is if this is your surrogate endpoint of benefit, you come to one conclusion. If edema is your surrogate endpoint of benefit, you come to a different conclusion. And so this is interesting. It's very reductionist. I don't know how you should integrate this information, but it does remind me to remind ourselves that one's endpoint of injury, we should be critical in thinking about which physiologic, if any physiologic endpoint matters. We got burnt with trying to optimize oxygenation of patients by cranking up tidal volume. We're being reminded that we may get burned again doing this with PEEP. And so we ought to be careful when we're using short-term physiologic studies, even though they have a powerful immediate feedback. We ought to be careful in terms of putting too much meaning into this. And so I, as far as the CO2 effect is concerned, cellular wound repair tends to be inhibited in a hypercapnic environment. The use of bicarbonate buffers is associated with fewer injured cells, and the effects of pH and pCO2 on cell injury and repair are distinct from their effects on water and vascular barrier properties. And I guess in the interest of time, I'll stop here.